Here's why. From now on, we're going to care about varicose veins. Welcome. I'm Dr. Jordan Robertson. I am the host of the Real Integrative Medicine podcast and YouTube channel. Welcome. Today we're going to talk about varicose veins. It's so common when we work with people with varicose veins as a practitioner that we're generally talking about aesthetic outcomes. Patients come in wanting to know what they can do to make their veins look smaller and less visible, or we just flat out ignore varicose veins, and it's not actually part of our history taking with our patients. Our patients may not mention it because it's genetic or they feel like it's something that they can't change. We really need to change the way that we think about peripheral vascular disease, chronic venous insufficiency, and varicose veins, with almost every single patient who has varicose veins progressing over a 10-year period. It's important that we have early conversations with patients about what's possible for them to do to change that trajectory, if anything, but also to help them understand those risks. It's so common when something is in a patient's life that they feel like they can't change, that they never mention it to their practitioner. It's also very common for us as practitioners that when something is going to live in someone's life forever, that we forget to actually question about it, to question if things have changed, to question if it's actually changing the way people feel day to day. And these clues or questions about varicose veins really teaches us a lot about what we can do to support people, but also helps us understand when we need to escalate the assessment for varicose veins. The grading scale for varicose veins, when we match that up against what the treatments that are available, is really fascinating. And this is sort of your ticket or your key as an integrative practitioner of where you can actually support patients. We have a grading scale for how we track varicose veins, and it starts out with a C0. So the scoring system is CEAP scoring system. What can be done in your office is grading things based on the C, right? So classifying those varicose veins. Patients who have no visible veins, who don't have any discomfort, they get classified as a C0, and then they slowly work up their way to reaching that C6 stage. Patients who have visible veins that are not symptomatic are generally a C1, and the moment we start to have symptomatic veins, and typically patients are going to describe that as being heavy, maybe they have achiness at the end of the day, that's going to put them automatically in that C2 category. What's fascinating is that, like I said, about 100%, so the one study that did track people over 13 years, 90% of patients progressed in a 13-year window, so they worked their way slowly up this grading system. It means almost 100% of people get worse if we just leave them alone. That we actually don't have any drug therapy until people reach about a C6. So when we get to the stage of having stasis dermatitis, when we get to the stage of having ulcerations, that's where we intervene medically. But we have years and years and years of changing veins and increasing risk of peripheral vascular disease where we actually don't have any solutions. So for you as an integrative practitioner trying to find that sweet spot of where you live with this particular condition, I want to walk you through what your steps are actually going to be to help support your patients so that you understand what your role actually is. The first one is in history taking, right? So it's so common that as an integrative practitioner, we're asking about all different body systems. This one gets left out. Asking about peripheral vascular circulation, about peripheral vascular disease often gets missed in a history taking. It's important that you ask people about their risk of varicose veins, their history with their veins, but also we want to try and find out what their overall circulation is like in the periphery. One of the challenges with that CEAP scaling in the past, if we just graded people based on the visibility of their veins, it left out a huge percentage of patients who have, maybe very smooth looking legs, but they're edematous, right? And the edema actually masks the visibility of veins. So your questioning and that discussion with patients needs to go beyond asking about aesthetics. It needs to look into the actual circulation challenges that your patient may be facing. We need to find out if both sides being equal, right? Do they have edema on one side versus the other? And we need to ask questions that go a little bit further than, do your varicose veins bother you? So that we can actually understand the risk of peripheral vascular disease. There's a big chicken and the egg conversation with varicose veins, whether venous hypertension comes first or whether that vascular remodeling that causes those dilated and distended veins comes first. But really, this is probably microvascular changes that's happening for decades before people actually start to accumulate risk. When we get venous hypertension mixed with that vascular remodeling, we end up with inflammatory markers and leukocytes in the area, which is related to that increased risk of clotting later down the line. As an integrative practitioner, we are always looking for whispers of inflammation, of metabolic changes. This is a perfect example of something that if we intervene early, we might change someone's course of disease over their lifetime, rather than watching them like the 100% of people that progress if we just leave them be. So history taking is incredibly important, and because health appointments can be so short, it's common that unless the patient is really symptomatic, maybe they have bleeding veins, maybe they are really struggling with the aesthetic of it, or maybe they actually have significant quality of life challenges or heaviness in their leg that would ask them to seek out treatment. It's uncommon that this is going to come up in a 7 to 10 minute health appointment. It's also uncommon that it would come up even in a regular physical exam. Like I said, you can't just look at the surface and assume we understand what's happening with varicose veins. We have to ask questions about deep veins we maybe can't see, get a sense of your patient's actual symptomology. We need to look at edema, and we need to look at both sides and make sure that the patient doesn't actually have maybe very smooth skin, but a lot of peripheral vascular congestion beneath the surface. And we also need to grade our patient's experience so that we understand if they need a referral. The moment patients start to be classified as a C2, so they have very visible varicose veins, they do require a baseline Doppler ultrasound to better understand the peripheral vascular system in that patient's leg. It's common that even if we have visible veins or significant veins only on one side, that the patient will have progression on the other side. I would think of varicose veins as more of a systemic condition than just one vein that's got some leaky valves. We actually need to think about it as something that's systemic, that's going to affect the patient's entire body at some point in time. This is probably why you've heard horror stories of recurrence after surgery. But if we don't clean up any of the pre-existing factors that cause varicose veins, that person's state is very likely to have recurrence, especially in the other leg after we treat one vein. So we want to get a good understanding of where our patients are at so we can make that appropriate referral. Patients may just have very visible veins. We send them for an ultrasound and everything comes back great, but that baseline really does help draw a line in the sand of how we understand their peripheral vascular system, and it allows us to more effectively track them going forward. Patients who have discomfort in their veins or who have bleeding veins or stasis dermatitis, or we're starting to see those skin changes as a consequence of peripheral vascular disease, are at a pretty increased risk of clotting. And so having that baseline assessment also helps put it on your patient's radar that the things that we want them to do, like compression and other treatments, actually are more important than if we just suggest them casually, right? That ultrasound actually helps your patient get more on board with the severity of their condition, and it's going to help them comply more. So as an integrative practitioner, you have a massive role to play here. This is something we don't question about a lot. It's something we have zero drug therapy for until people are quite severe. And we can help actually get momentum in your patient's case by referring them where they need to go to get the right assessment they need for us to better understand their baseline status. The second area that you're able to help these patients with is actually that sort of C0 all the way up to C6 therapy. So when we look at the standard of care guidelines for how we support people before we offer them pharmaceuticals, this is exactly what you do on the regular basis with your patients. There's discussions around exercise and that muscular pump to support peripheral vascular disease. Micronized purified flavonoid fraction, MPFF, which is actually a venoactive substance that prevents the leaking of fluid outside the veins. It also decreases that leukocyte accumulation. And we know when we watch people long-term who use supplements like that, they actually have a decrease in the progression of their varicose veins, which is amazing. So the very things that are in the standard of care guidelines are actually things you'd recommend. The last one being compression, right? We know that if we use compression therapy in people who have significant veins, we are decreasing the risk of a DVT. The amount of coaching and compliance management it takes for people to do compression well is very much in your scope and is something that you're able to actually support people with. So there are so many things that we can do to support patients before they get to that C6 and maybe requiring medication to manage. And again, knowing that 100% of people progress over 10 years, there's a huge role that you get to play in supporting someone's peripheral vascular disease. The last sort of third way that you get to support is actually post-surgery. So surgery is incredibly effective at dealing with the vein in question. Like I said, some patients will have recurrence. That's probably because the underlying risk factors are not changed or solved, and also that change in varicose veins is probably something that's happening over many years. And so by the time we treat one vein, there are other veins that are on their way to requiring support or perhaps surgery. I think sometimes we look poorly upon recurrence for surgeries like this, forgetting that those underlying risk factors that made a patient at risk for having this condition in the first place are not solved by surgery. But surgery is incredibly effective at dealing with the vein in question. Patients do very well when they combine their surgical options with their integrative support, including things like MPFF and compression after surgery. Patients have less pain, they have better healing rates, and overall better experience if we combine what you do with the conventional support that they're receiving from their doctor. So, there's so much that you can do to support patients with varicose veins. It really comes back to the identifying it. And we really pride ourselves on being great history takers and being someone who is going to get in there and find the details of someone's case. And yet, you have to ask yourself, in the last 100 patients you saw, how many of them did you ask about their varicose veins?